very much. Thank you for the invitation. It's very nice to be here. I've never been in Slovak Republic, so it's very nice to discover another European country. I thought I knew them all, but this is a very nice place to be in the heart of Central Europe. So you gave me a topic. First, I'm very happy to see that NASH is an increasing topic of interest in this side of the world and in this part of Europe. And you gave me a very narrow topic, actually, only talking about epidemiology. So I'll try to focus on epidemiology, but I would also like to give you some background about NASH. So the problem, of course, is that obesity is becoming more and more prevalent across the world, and it's not only a problem in developed and rich countries, it's also a problem, paradoxically, in countries in development, where obesity and diabetes become a very, very prevalent disease. 2 billion people are now overweight, more than 600 million are obese, and in the United States, it's very hard to find someone that is normal weight. Everybody is either overweight or already obese. Now, the explanation for that is that, of course, is the environment, is the things we eat. You can see that portions got much bigger than 40 years ago and much more hypercaloric. And this, in combination with the fact that we have a very sedentary lifestyle, we don't do enough exercise, explains why this obesity epidemic is becoming more and more of a problem. Now, you asked me to talk only about European data. So the only slide that shows United States data is shown here. But this is a very important slide, in my opinion, because it tells you that currently in the United States, or at least parts of the United States, the #1 cause of cirrhosis is becoming NASH. This is a survey performed in hospitalized patients in the whole western part of the United States. And you can see here that these are all cases of people hospitalized with cirrhosis, decompensated cirrhosis. And you can see that the #1 cause of cirrhosis in this survey is NASH, in red, 29%. And then alcohol, 27%. Then you have hepatitis C, 22%. And the orange part here is cryptogenic liver disease. So if you think that at least half of the patients with cryptogenic liver disease actually have NASH, well, then you have to add another 5% to the 29%. So clearly, at least in parts of the world, NASH is now becoming the #1 cause of cirrhosis. But of course, you need to recognize NASH. So when should we think about it? When do we need to recognize it? What are the clinical circumstances where we need to think about this diagnosis? And I think that basically there are 3 circumstances. First of all, when you have demonstration of steatosis on imaging. You have to think about, of course, NASH if there's fat in the liver on imaging. And that's very common because we do ultrasound for all kinds of reasons. The second thing is when you have metabolic risk factors. And that's the tricky part because most of the time we don't look for these when we examine a patient in liver and GI. So you have to look for all the metabolic risk factors you know and which are listed here. So it's not only overweight, but also waist circumference. You have to measure visceral adiposity. You have to measure hypertension, glycemia, dyslipidemia, and so on. And the third circumstance, of course, is altered liver function tests. So transaminase or gamma-GT, I don't know, in your countries, if you use gamma-GT like France, or if you use phosphatase alkaline like the United States. But all of these can be altered. So when you have these 3 things, or 2 of these 3 things, or even 1, you have to think about NASH. And I say even 1 because #1 cause now of increased transaminases in the general population is NASH. So you have to look for this disease. Now, of course, the problem comes that NASH is by definition an exclusion diagnosis. You need to make sure the patient doesn't have other liver diseases, but sometimes they do. And it happens that they can drink and be obese, or it happens that they can have hepatitis C and be obese. And it's not because they drink that all of a sudden obesity disappears. It's still there. So we have to change the way we think about NASH by recognizing that it can be an association. You can have a mixed etiology. You can have morbid conditions of liver disease. So you can have NASH and alcoholic liver disease. So in order to show you this with some data, the association between alcohol and metabolic liver disease, we performed a study that was published 2 years ago where we looked at people listed for liver transplantation. They had actual liver transplantation, and they had it for alcoholic cirrhosis. And we looked at the patients how many of these patients actually had liver cancer in addition to cirrhosis due to alcohol, okay? And when patients had steatosis only, meaning just alcoholic liver disease, 16% of them had liver cancer. When they had metabolic risk factors, meaning diabetes, obesity, dyslipidemia, hypertension, in addition to steatosis or alone, the proportion of liver cancer was 47%. So the more, if you have alcohol plus NASH, the proportion of liver cancer goes higher. So that tells you that there's a synergistic damage between these two conditions, and they do not exclude each other. So be aware of associated diagnosis here. So metabolic risk factors can coexist with alcoholic liver disease, and they increase the risk, for instance, what we've shown here, of liver cancer. Now, another very interesting study has been performed in Finland. And it's a study in the general population where they try to understand how much of the liver disease is explained by metabolic risk factors. So they looked in the general population, and they looked at both alcohol consumption and cardiometabolic risk factors in the general population in 6,771 subjects. And they tried to understand whether metabolic risk factors predict complicated liver disease, meaning cirrhosis and its complications. And they stratified that by alcohol consumption. And they only looked as an outcome at severe liver disease, hospitalized cirrhosis, complications of cirrhosis, liver cancer, liver-related death. And the results are very interesting because you can see here that, of course, here are the predictors of end-stage liver disease, the things that independently predict complications of cirrhosis. So you look here, you can see, of course, that alcohol predicts complications of cirrhosis, but you have a whole bunch of metabolic risk factors, including diabetes, including insulin resistance, including BMI, that independent of alcohol predict complicated cirrhosis in the general population. So that was true for both men and women. And it was also true when you stratify by the amount of alcohol people drink. So if you drink less than 20 grams and 30 grams, which are the thresholds for defining NASH, the metabolic risk factors were all independent predictors of complicated liver disease. But then even if you drink more than that, so people who have more at-risk consumption of alcohol, diabetes, which is the most severe insulin-resistance associated disease, was still an independent predictor with a very high hazard ratio here for complications of liver disease. So in the general population, regardless of alcohol, metabolic risk factors contribute to cirrhosis, contribute to liver-related death. Now, when you see a patient with the three things we've seen, steatosis, altered liver function test, or metabolic risk factors, what is the diagnostic procedures that you do? What's the diagnostic path you follow? So most of the time, we're dealing with the regular NASH that is associated with insulin resistance. But sometimes, and you have to systematically exclude, there are secondary causes of NASH, which I tried to list here. There are drugs that induce steatosis. There are genetic diseases that induce steatosis, like hypobeta-lipoproteinemia, like lysosomal acid lipase deficiency. These are very simple things that you can test with regular standard biochemistry tests. And then you have, of course, Wilson's disease, and there have been described some more rare diseases. So you have to make sure that the patient has none of these secondary causes of non-alcoholic fatty liver disease, okay, steatosis. If it doesn't, then you're dealing with primary NASH, NAFLD. And primary NAFLD is, by definition, associated with metabolic risk factors, which are all listed here, which are the same ones that I've shown you on the slide before, okay? Then you're dealing with primary NAFLD. Now, I'm sorry. Oops. So sometimes what you need to do, of course, is when you have a suspicion is to consider whether there are other causes of chronic liver disease. So you eliminate viral hepatitis, evaluate alcohol, autoimmune liver disease, genetic, hemochromatosis, and all that. And then you have also to look for the metabolic risk factors I've shown you. Now, sometimes they're absent, okay? Now, when they're present, that's primary NASH. When they're absent, what you need to do is to have a more close examination of fat distribution, because sometimes people can be overweight, and then it's easy to diagnose, but sometimes they're not overweight, they're normal weight. But the problem is that they have fat in the wrong place. They have fat in the abdomen, they have fat in the muscle, instead of having fat in the adipose tissue. So you have to measure fat distribution. You have to measure waist circumference. You have to look for the HOMA index, so measure glycemia and insulin, HbA1c, and look also at ferritin levels, which can be increased in the metabolic syndrome. So sometimes people do not appear to have metabolic syndrome or overweight, but if you do these tests here, you will see that they already have insulin resistance. So that's the way to measure it. And if that's the case, then you're back to primary NASH, which some people call lean NASH because they're not overly obese. If that is not true, if you cannot find any of these, I'm going to skip that. If you cannot find any of these, then you have to look at drugs, toxins, alterations of lipid metabolism like hypo-beta-lipoproteinemia, and you have to look for Wilson's disease. If that is still absent, you have to do a test for lysosomal acid lipase deficiency. This is a genetic disorder that is very rare, but that can induce steatosis in someone who does not have insulin resistance. And nowadays, it's very easy to diagnose. You take a drop of blood in the outpatient clinic, you put it on a paper, it's a dry blood spot test, and it measures the enzymatic activity of the enzyme. And if it's low, then you have to do other tests to confirm it. But that's a very easy screening procedure for this very rare genetic disease. And if you do all that, most of the time you find the cause for steatosis. Now, that seems very easy, but in real practice, a lot of people are not diagnosed. And that is a big problem because awareness for this disease is very low. And there are parts of the world when even though you have all the factors we've seen, people still don't diagnose the disease. This is a very nice study that was performed in the United States when they looked at more than 500 medical files and identified people that were high BMI and altered liver function tests. And they looked whether the doctors diagnosed the disease. And as you can see here on this slide here, 60% of these cases where the diagnosis was clearly evident, the doctors did not even identify NAFLD. And they only identified it in 40%. And most of the time, they didn't do anything about it. In 39% of cases, they said, okay, there is increased ALT. Only 21% of cases, they say, okay, increased ALT is due to NASH. Only 15% of cases, they say to the patient, do something about it. Try to change lifestyle conditions, try to eat less, try to exercise more. And only 10% of cases, they send it to a specialist in order to take care of dyslipidemia, diabetes, arterial hypertension, and so on. So there's a very, very low awareness for this disease currently, even in centers that are, secondary or primary or secondary care centers. Now, although the disease there's a low awareness, the disease becomes more and more prevalent, at least in hepatology. This is a very nice study performed in Scotland, when they looked at a very large number of people from a diabetes and the National Hospital Registry. And actually, they looked at people who died of cirrhosis or who were admitted at the hospital for cirrhosis, so very severe liver disease. And they compared cirrhotics versus non-cirrhotics. And they looked at the causes of liver disease that induced cirrhosis and the complications that justified hospitalization. And they saw that in patients who do not have diabetes, right, non-diabetic patients, the number one cause of liver disease that induced cirrhosis and complications was, of course, alcohol. But the number two cause was NASH. Now, in patients that were diabetic, it was the opposite. The number one cause of cirrhosis and complications was NASH, and the number two cause was alcohol, and then much less for autoimmune liver disease, hemochromatosis, viral liver disease, and so on and so forth. So at least in the population of high risk, like the diabetics, NASH is the number one cause of severe liver disease, not just increased ALT. And interestingly here, you can see that if you look at the socioeconomic status, people that are very poor, people that are very rich, and you divide that in quintiles. 0 is the poorest, and 1 and 5 is the CEOs of the big companies, okay? So you look here at the distribution of alcoholic liver disease is very common in people that are at a low socioeconomic status, both in men and in women. But NAFLD, it's a very egalitarian disease. It touches everybody across all distributions of wealth and income and social status. So except for those that are very rich that can spend all their holidays golfing in the Grenade and in the Bahamas, all of the others have a very high proportion of NAFLD, and it's not dependent on the socioeconomic status. So we're all equal in front of this disease. Now, what is particularly concerning is that obesity and diabetes start earlier in life now than they used to start 20 or 30 years ago. And this is a study performed in the Lancet where they put together hundreds of thousands of patients. And you can see here that there is a very strong increase nowadays in the proportion of obesity in both men and women, in both developed and developing countries, rich and poor countries. And there's an increase that starts already at 10 or 15 years of age. And the big increase is during adolescence and early adulthood. And the problem with that, of course, is that if you start early in life with obesity and diabetes, you'll end up having the complications of NASH very much earlier in the adult life. And this has been shown for liver cancer. This has been shown with cirrhosis. People who start very early, they will develop these diseases and their complications at a much younger age than what we see nowadays in our patients. Because for the moment, cirrhosis occurs around 60, 60-something, and liver cancer 70 in NASH. But because of these people becoming more obese earlier, we'll see the mean age of diagnosis happening earlier in life in the future. And this is from publications we have shown, which basically shows the interactions between environment and age. And you can see here that when it starts very late in life, you will never reach the complications of liver disease because you're going to die of other diseases. But if it starts early in life, you'll reach them much earlier, and then liver disease will become the predominant cause of death. Now, there's very few studies that have, in fact, looked at the prevalence of NASH in the general populations, which is what you asked me to describe nowadays. This is a study performed in the United States, so I'm not going to comment. But this is a nice study from England, where they looked basically in a primary care setting, everybody who had increased ALT. And they tried to understand what are the reasons for increased ALT in the people that were not selected in primary care practice. And after they did all the etiological workup, you can see here that the number one cause of increased ALT in England was NAFLD. Number two cause was alcoholic liver disease. Here, 2 or 3% is the whole textbook of hepatology. All the liver disease we learn, it's only 2 or 3%. And then 45% of cases, no clear cause, either transient elevations or no cause that was recognized. Now, they didn't do a liver biopsy here. They did the serum markers of fibrosis. And the percentage of advanced fibrosis on serum markers was 2% of the general population, which is very high, much more than hepatitis C or B. So the natural history, the current paradigm until a few years ago is that basically this disease exists in two varieties. Either you have just fat or you have steatohepatitis, which is fat inflammation, liver cell damage. And this distinction appeared to be important because people who only have, people who had steatohepatitis, they can have fibrogenesis. And that can go, it's a long process, but will ultimately result in cirrhosis. Whereas people that have only steatosis, normally they do not develop cirrhosis or advanced fibrosis. And for the longest time, we thought that there is here a clear division, and you go either like that or like that, and then you don't change anymore. But now we have published some studies where it has been clearly shown that people can transition from steatosis to steatohepatitis. And this transition here is when the metabolic risk factors persist or get worse. So this is just plain steatosis. This is steatosis with balloon cells. Meaning pre-necrotic cells, damaged hepatocytes. And I think here you can see very, very severe balloon cells on this part of here. And those are normal hepatocytes. And this is an example of different stages of fibrosis, just simple portal or perisinusoidal fibrosis. More advanced perisinusoidal fibrosis, you get bridging fibrosis here. See the bridges? And then you get cirrhosis with their nodules. So what we have shown in some studies with serial liver biopsies is that people can progress from steatosis to steatohepatitis and also then go on to develop severe fibrosis. And this is basically a study we published a few years ago where we had taken only patients with steatosis, just plain steatosis, and rebiopsied them several years later. And none of them were expected to progress based on what we knew on the natural history. However, more than half of them progressed from steatosis to NASH. And some with severe NASH here. And if you look at the red bars here, some of these people actually also progressed to bridging fibrosis. They had zero fibrosis here, bridging fibrosis here. But what I want you to see here is that almost all people with bridging fibrosis, they were in the NASH category. So when you develop severe fibrosis, it goes together with the appearance, the occurrence of steatohepatitis. And please remember this. So now, the natural history view of the disease is the following. You can go through all these states here, from simple steatosis to steatohepatitis, and once you're here, fibrosis will start developing. Now, there's a proportion of people with very early fibrosis, which might be very fast fibrosers, and some are very slow fibrosis. And they all go to develop cirrhosis if they live long enough. And then when you have cirrhosis, you can develop liver cancer. Now, this is the old paradigm of cirrhosis being a preneoplastic state. However, in NASH, like in hepatitis B, you can have liver cancer developing from almost all stages of the disease, not only cirrhosis. So you can develop liver cancer even on a non-cirrhotic, steatotic, or NASH liver. And this is also something very important for the natural history of the disease. So steatohepatitis, as I explained to you, is a more advanced state of the liver damage, which predisposes to fibrosis progression. And therefore, there is a higher risk for the liver. More severe inflammation, more severe fibrosis. But steatohepatitis also is a state of more severe metabolic abnormalities, because it is associated, if you compare just with plain steatosis, with more insulin resistance, more cardiovascular damage, more diabetes, etc. Okay? So steatohepatitis damages the liver, but also has systemic complications. It gets insulin resistance worse. So this is a very nice study, again, performed in a general population in Holland, where they took everybody that was older than 45, and they did, without any selection, and they did two things. They did ultrasound to look for steatosis. They did fibroscan to look for fibrosis. And the results are very interesting, because in this general population, 35% of people had steatosis, very high, okay? Now, some of them, steatosis was explained by alcohol, drugs, HCV, etc. But 27% of them, no explanation other than metabolic steatosis. Now, they performed fibroscan in everybody, and they noticed that 2.3% of the general population had advanced fibrosis, totally asymptomatic. And these are the ones of the 27% here. So you can see there's a very large prevalence in the general population, if you look for it, for advanced fibrosis due to NASH. And actually, here are the determinants for advanced fibrosis. Of course, men are higher risk than women, age, but also smoking. Smoking increases liver fibrosis. And of course, the metabolic syndrome, diabetes, insulin resistance, all these factors were independent predictors of advanced fibrosis. Other studies have looked at the same thing, but with biomarkers. So here you have FibroTest that looked at healthy subjects, and you can see that the same prevalence of fibrosis or cirrhosis can be seen here. And this study here was done with fibroscan in the general population, pretty much the same prevalence of cirrhosis depending on how you measure it, which is due to NASH. So I think that what we can say here is that in the general population, probably 25% of people we see have NAFLD. Among these, 10% have NASH, so 2.5%. And among these, 10 to 15% may have advanced fibrosis or cirrhosis. So these are very conservative estimates. Of course, when you go back to work Monday, in your clinics, it's not that, it's here. You all work in secondary or tertiary care centers. So what you see here is much more severe liver disease. But the problem is that, of course, this is not a reflection of the general population, but is a referral bias. So I will finish with some data we have in Europe regarding the burden of disease. There are very few studies so far, but this is a nice study performed in Germany where they looked at the costs of hospitalization and medical resources that are being used for patients according to whether they have steatosis, increased ALT, or a combination of these. So they looked at more than 4,300 patients, followed them up for 5 years, and they classified them according to whether they had steatosis, increased ALT, or none or both. You can see here that most patients were normal, but some people had either steatosis or increased ALT. And then they looked at how much more money is spent in people who have steatosis versus those that have not steatosis. or the same for ALT or the association between the two. And you can see here, that's the percentage here of how much more money is spent as compared to people who have nothing, okay? So which are here, they're all at zero. So all this is, you can see basically that's between 15 to 30 to 40% more money spent, depending whether you look at outpatient visits, costs, length of hospitalization costs. The fact that you have this disease costs 15 to 40% more than not having the disease. So it adds a significant amount on the healthcare cost in the general population. So you can see here that patients with fatty liver and increased ALT had 37% higher overall costs of health, 18% more outpatient visits. They spend more time in the hospital, and the hospitalization costs more money than in people who do not have steatosis. So these are the only data we have on the socioeconomic impact in terms of healthcare costs of NAFLD, but I'm sure other studies will follow in the future. Now, all this talk will not be very important if it's only about describing the reality of the disease. But fortunately, now we start having drugs that can maybe change the natural history of the disease. And I listed here all the drugs that are now in development. You are certainly aware of obeticholic acid. I don't know if in your countries is already on the market for primary biliary cirrhosis. But not for NASH. They're in phase 3 for NASH. And there's another drug, which is elafibranor, that is in phase 3 for NASH. Those are the first generation FXR and first generation PPAR dual agonists. So these drugs will have the results, I think, 2 years from now, and we will know whether they will be marketed for NASH or not. So very advanced stages of clinical trials. But some of them, especially obeticholic acid, which is a first generation FXR agonist, have side effects. So therefore, people try to develop second generation FXR agonists. There are 6 or 7 of them in development. The most advanced one is tropifexor from Novartis. They are now starting large phase 2b trials, and this is in development. And then you have a lot of other drugs that you heard about if you went to the EASL meeting in Paris 1 month ago. You have metabolic regulators like FGF19, FGF21, which is made by BMS, ACC inhibitors, which are made by Gilead. You have GLP-1 receptor agonists made by Novo Nordisk, which is semaglutide. You have other drugs which are SCD1 inhibitors. All these drugs inhibit lipogenesis in the liver. And then you have anti-inflammatory agents that are developed. Selonsertib is in phase 3 for NASH, is made by Gilead again. This is made by Allergan, an anti-inflammatory agent. And then you have other ones by Boehringer and a whole bunch of other drugs in development. So there's a very, very large number of molecules that are being tested now, either at early stages or more advanced stages for this disease. And this is a very, very active field of the disease. So each time I was in charge with some of these trials, I argued a lot about including Eastern Europe or Central European countries in these trials. So I know Professor Urbanek from the Czech Republic was one of those that participated, other people from Poland, some from Romania. But it is very important that people take part in these studies. First of all, that's how we get drugs on the market, otherwise we'll never get them. Second, it helps you really be on top of the research that is being done in this therapeutic field. Third of all, these it gives you something for your patients, even though it's a test for some time. And also, these trials are very well structured from a legal and ethical point of view, and it brings money to the institution. So please contribute to these clinical trials. The only thing is that you have to do liver biopsies. So I think I'm going to stop here. Apologies if I was a little bit too long, but I hope I provided you with an overview of not only of the epidemiology, which is a bit boring, but also the medical management of these patients. Thank you.